Now, without further ado, I want to introduce Dr. Berman. He has long experience in practice of medicine and also the management roles. He practiced in multi-specialty groups, clinics, and private practice, rural private practice, sports medicine, student health, nursing homes, hospice, and assisted living. He also has extensive administrative experience in private practice with heading a internal medicine group and managing a sports medicine practice, hospice medical director. After that, he became Medicare CMD Part B, Georgia, RAC CMD, the one we have been talking so much about it. And after that, he became CMO of CGS. I have known him ever since they took over Kentucky. Before it was NGS, and has been a very good association. Dr. Berman is always available to discuss issues. We can call and talk to him. He always promotes the four corners of communication, which we adapted actually: clear, concise, correct, and considerate. So now Jessica is here and Stacy. They have extensive experience, as you have seen yesterday. And thank you again to all of you. And let us go ahead. Thank you.
Thank you for that introduction. And it's always interesting when I hear an introduction because I feel like I have to live up to all the compliments. So I do appreciate that. And as always, Dr. Manchikati, you know that I believe ASIPP is such a well-run organization and so involved because of your leadership. And I do appreciate the communications and the collaboration that ASIPP and you and other members of the pain management, especially the interventional pain management organizations and providers have with CGS. So if we can get to the first slide, I think y'all are controlling that.
Yes, of course. Just share my screen here.
So today we were assigned about an hour. We're happy to go over if needs be. I do want to thank Jess and Stacy. They volunteered to be here today. I never impose weekend hours on our other staff members, but you truly have the experts. I'm here just as a moderator and to listen to their expertise. And I want to just thank them publicly for taking time out of their family and their personal time to be here today. Today, for this hour, we're going to try and go through some program integrity information. We will cover some information we hope will be useful. And if you have questions, we're happy to answer them. If they can wait to the end of the session, great. If they have to be asked in the middle, we're happy to pause. I know that y'all had an extensive session yesterday with Meredith, our policy CMD. And I'm sure you got all the information you needed clearly from her, Jess, and Stacy. But if there's some holdover questions, we can do our best to try and answer those as well. Can you go to the next slide, please? This is a standard disclaimer, and basically it just tells you that when the slide set was put together, which was on February, it wasn't put together today, but when it was put together a few weeks ago, all the information was up to date. And you'll see an example how we're not 100% up to date at the time of the slide deck presentation in just a few minutes. So we can go to the next slide, which is the agenda. I'm going to speak about medical record review, just an overview, and the CERT program, Comprehensive Error Rate Testing Program. Then Jessica will cover the TPE program, which I know some of y'all have been involved with. And then Stacy will cover the prior auth, and I'm not sure who's covering the RAC and UPIC audits, but one of us will pick that up. Either I will do that or Jessica or someone will do that. I'm not sure exactly who's handling that, but we'll figure it out. I will tell you my background, just very briefly. When the RAC program started, I was the only medical director for the RAC during the demonstration. And then I was employed by PRGX, which was a subcontractor for 75% of the country. So The RAC program has evolved, but I still have a pretty decent understanding of how it works and how things are done. So I can't answer formally questions in regards to how they operate and what they do, but general things I'm happy to discuss if needs be. Can you go to the next slide, please? Start off with medical record reviews. Next slide, please. So in general, we have statutory authority, as you can see at the bottom of the slide, through the Social Security Act, these three sections. I'm not going to read this to you because I'm sure everybody can read, and the slide is pretty clear. But I did want to say that when you sign up, when you enroll in Medicare and you sign the conditions of participation, you basically are authorizing us to request any medical record and any treatment course. We can look in the computer at your billing history, all of these different things. You sign that over to give us authority to do so under the Social Security Act and your conditions of participation. This is not only from a program integrity standpoint, but we are able to do this and also to see about compliance in general with our policies, any other information that we need to look at in order to determine whether or not the services that you have rendered to our beneficiaries in Kentucky and Ohio for the Part B program satisfies medical necessity requirements. Now, medical necessity is something that we, by 1862A1A, we will sometimes deny a claim, or you'll hear us educate people on medical necessity. Now, that's a confusing statement. It is required by CMS for us to call claims medically necessary. Now, that implies that you may be providing a service that you do not believe the patient needs. Medical necessity does not mean that. Medical necessity means does it satisfy the 1862A1A, which in layman's terminology would be, is it the right doctor or provider, the right provider performing the right service to the right beneficiary in the right frequency and the right setting, and basically satisfying the rules, regulations, statutes of the Medicare program. Now, we write policies, as Dr. Lovelace went through extensively yesterday, and those are not regulatory, but they are rules. So as a provider of Medicare, you're required to follow them, or you would receive a medical necessity denial. And again, you can provide whatever service you feel to be necessary, but it may not be covered or paid by the Medicare program. So that's a very important distinction and explanation that I needed to get across as part of the medical review, because Jess and Stacy will be covering for their designated areas, TPE and prior auth. They will use medical necessity as a basis for acceptance or denial of the validity of the claim satisfying those rules, regulations, or statutes. So it's very important. When they say medical necessity, providers get upset. I testify for the U.S. Attorney's Office in court for Medicare fraud, and I'm their subject matter expert on Medicare rule and regulation. And providers get very upset when you say this isn't medically necessary. And the first thing they say is, who are you to tell me what I can do with my patient? I can't tell you to do anything or not to do anything. I can just explain to you whether or not it satisfies rule, regulation, or statute. Next slide. So we have the privilege and authority to request medical records. And when we look at a claim and we make a determination that we need to review that claim, we can request medical records. Now, when I get to the next section, I'm going to talk to you about the importance of sending in medical records. It says here in the first bullet point, again, I'm not going to read this, but you should send in a comprehensive, not necessarily 800 pages, but a comprehensive medical record that allows us to verify and validate the medical necessity for Medicare to coverage and pay that claim. Now, if you look at the ADR request, ADR stands for Additional Documentation Request. If you look at that, there will be a formal bulleted list of things that we need. Then there'll be a sentence in there that says, and I'm going to paraphrase, anything that you believe verifies and validates payment of the claim. Now, that's important Because if you just send in an op note or a procedure note, and it doesn't satisfy the regulation or the rule that Dr. Lovelace has established in our policies, such as the fact that the patient went through a non-invasive or conservative treatment and failed, or a pain scale, if you don't send that in because that's in your office note, not in your procedure note, then that would be denied as a medical necessity denial. Or if the TPE reviewer feels like they need to follow up with some additional information, they will send you a further additional documentation request. Next slide. Go ahead and do 2 slides, please. Okay. So what is the CERT program? The CERT program is a federal program that was initiated to tell the country, and most importantly the legislators, how MACs and other review entities do their job. They review approximately 20,000 claims out of the billions of claims submitted, and they determine an error rate. That error rate has been utilized by not only MACs, such as us, to determine what our plan is for the next year, because the CERT data directly informs our strategy. If a particular process, procedure, or provider, and by provider in this instance, I mean a global specialty, has a high error rate, then that will be part of our strategy. Our strategy is to determine not only where the errors are coming from, but how through education, and that's what Jess is going to talk about because she's our subject matter expert on education. She's going to discuss how we can, after review, educate providers to reduce that error rate. So the CERT program is required to look not only at statutes and regulations, but billing instructions, not only from CMS, but from MACs, LCDs, NCDs, and also IOM references. So they are to apply the information that you have access to, and we have access to. They apply that to claims review, and then they determine an error rate. If I can have the next slide, please. This slide is an example of our disclaimer. When the slide deck was established, these were the error rates from the Medicare report. I do have updated error rates that I'd like to share with you. We're going to primarily talk about Part B. So here you can see, actually, I'm not going to update. This is a national error rate. Part B providers nationally had a 10% error rate. Now, 10% of the Medicare program equals 11 billion with a B dollars. $11 billion of error. Now, for J15, Part B providers had a 16.1% error rate. So Part B J15 is 6% higher than the national general Part B provider error rate. Just so that you'll know, we drilled down on this. Insufficient documentation was 64% of that 16.1% error. So well over 50%. Now, what does that mean? And why did I emphasize 64% and I emphasize insufficient documentation? If we ask you for information that would verify and validate payment of the claim and you don't send it in, that's an insufficient documentation. What that means is we did not have adequate documentation, verify, validate the fact that you satisfied medical necessity documentation requirements. It could be as simple as not sending in an office note or not sending in a pain scale. It could be very simple. Now, why is that important? I'm going to give a little historical perspective, but I'm not going to bore you, I hope. When the RAC program came into existence, one of the biggest complaints was doctors said, now it's just another entity reviewing us. And I said, the truth is, these are improper payments that are easily correctable with documentation. And we all complain. I just very recently went out of full-time practice because of this job, being the CMO of the company. But we all want to have a steady and or increasing salary or pay schedule. Unfortunately, Medicare every year somehow lowers the payments to physicians and to hospitals. Now, Medicare is a budget neutral entity. So when you have $11 billion being paid to Part B providers in error, and around 65% of that is documentation problems, most of which are simple to solve. Always, especially when I was with the RAC program, but even now when I have the opportunity to stand in front of 43 ASIPP providers, I beg you and implore you to make sure that your documentation is clear, concise, correct, and considerate. The clear part is, if you send a record that my nurses have to flip a coin on, there's a 50-50 chance it's going to fail. So make it clear, correct. We have a policy that's published that tells you exactly what needs to be in the medical record. Get your super user for Epic or your template developer to make sure those pieces of information are in the medical record. And tell your office staff, it's always interesting to me, the lowest person in the office is one who has to pull the medical records and send them to us to tell us whether or not you satisfied Medicare program requirements. Make sure they know with a checklist, and we provide those, by the way. Get that checklist, and that's their metric to keep their job. Send in information that allows me to get paid for this claim. When I was a managing director or managing partner of a big medical group, you know, we used to provide all these benefits and to our employees. And one time at a staff meeting, I said, why is it when I walk by the appointment desk, you say Dr. Berman doesn't have room in his schedule? I said, just remember, if I don't get a raise, you don't get a raise. So that's a side comment as to if Medicare is auditing your charts, whether it's us, the MRAC, RAC, CERT, or your a Medicaid or Medicare Advantage or a private insurer, have a checklist so the medical record is sent in complete and correct. It's very simple. If that is done, again, I talk to hospitals too, but if that's done, the Part B provider error rate, if it went down to 4% or 5%, they want it below 7% nationally. If it got down to 5% and that 11 billion went down to 5 billion, which the federal government feels is an acceptable rate, that's $5 or $6 billion that would go to budget neutrality and help us maintain our salaries. I know none of us are here just for the salary, but we do have to pay our staff and pay our bills. So it's important not only to satisfy Earl Berman and his medical directorship and CGS, it's important for you every day that you're in practice and make sure that that documentation is correct, considerate, make it easy to read, understandable, comprehensive. It doesn't mean 800 pages. It means what you send in is comprehensive and satisfies Medicare rule and regulation. That would not only help me, but it would help you. Go to the next slide, please. I'm going to now turn it over to Jess. She's going to talk about TPE. Again, my appreciation, I cannot state it enough for Jess and for Stacy to be here. I'm going to go on mute, but I will be available, and I look forward to answering any questions. Unless there's a question now before we transfer over to Jess, I'll have to leave it up to Dr. Manchikandi or David, someone who's monitoring the questions. If it's something I need to answer now or it can wait. Again,
So
thank
there
you
is
very
a
much
question, if you, Dr.
All right.
Berman, if you want to answer that. It's the question is, or a comment. So 11 billion in improper payments, but over half of that is incorrect documentation, then at least 7 billion is not improper. So how much does it cost to employ all the review employees and the process of seeking this out?
Well, I mean, the short answer is that we're paid administrative costs out of the Medicare program. It is part of their budget. The exact cost per review entity or review nurse, I have no idea because I'm not involved whether the Part B provider rate was down to $5 billion or not, the Medicare budget would not only include salaries to you, but salaries to companies such as mine. So review and adherence to regulation and rule will continue regardless of what the error rate is, because it has to be maintained by federal regulation and rule. If you want to get rid of us, go to your legislators. But I can guarantee you that you don't want this 100% in the hands of CMS. You want it on outside entities, non-bureaucratic entities that have practicing or previously practicing physicians and nurses assisting, and in collaboration and partnership with agencies such as organizations such as ASIPP. Dr. Manchicati, just so that you'll know, he's very humble. He is very active. When a policy comes out in the pain management area, he and his staff are extremely actively involved. So I can guarantee you'd much rather have him involved with us as opposed to the massive bureaucracy at CMS. I know that question was an honest question and it's heartfelt, but I think that you have to understand review entities such as us will always be in place, and the cost is part of a budget that is not involved in you getting paid or any outflow of money to providers or any other such thing like that. It is, when you look at what CMS does and all the different insurance companies, all that stuff, what we get paid is, a drop of blood in an ocean, to be quite honest. But thank you for the question. I appreciate it. Any other questions I can answer, Dr. Manchicati, before I turn it over?
No, we can answer later. So thank you.
My pleasure. Jess, I'm going to turn it over to you for TPE. And again, thank you very much for coming today.
Thank you, Dr. Berman. It's my pleasure to talk with you all today. So I will jump right into Targeted Probe and Educate program. I know some of you have participated in this program, so you've probably heard my spiel already. But we'll jump into the next slide where I will go over the components of Targeted Probe and Educate. With Targeted Probe and Educate, and you can just kind of go forward on the words. I don't know why they're popping up that you need to press enter to get there. You go. The MACs are going to focus on specific providers that bill particular items or service rather than all providers billing a particular item or service. So there's a targeted approach to Targeted Probe and Educate. With that, then we'll jump into the probe aspect of it. And what we're going to look at is 20 to 40 claims per provider for that service. So that's going to be considered one round. Prior to 2014, when CMS implemented a Target Probe and Educate, there was just widespread reviews, and each MAC could determine how many claims they wanted to review and what providers they wanted to review and how they wanted to complete their reviews. So Targeted Probe and Educate really gives precise direction on what we're doing with reviews. And then after each round, you are offered with CGS, regardless if you pass that round with the appropriate error rate, or if you're above that error rate and you have to go on to the next round, we offer education to everyone that participates in TPE. I've educated those that have had 0 errors and just gave a general policy overview, up to those with 100% error rate. I'm happy to educate everyone. After that education component, if you are moving on to the next round, round 2 or round 3, that would begin 45 days after the education. So you're given time to do process improvements, educate staff, kind of get a breather before your next round. My next slide will kind of go over the TPE process after the review. So the letters with the review results, and I call those final results letters, if you're ever on my education call. And with that, you will get number of claims we looked at, number of allowed, number of denied, and also a complete list of each claim and the rationale for either the allow or the deny is going to be in there. So you have a detailed understanding of what went on with your review. Again, you're offered individualized education. where those errors are discussed, any questions are answered. We go over the TPE process, we go over policies. I go over claims that are denied. I try to have like screenshot examples, because if you were on yesterday's call, you know I'm big on screenshots where I can walk you through what we are seeing is wrong with that record. I like a lot of web-based presentations like today's call, but we can also do traditional teleconference, and there's other methods available. When a high error rate continues after 3 rounds of review, what the MAC does is they send that referral to CMS for additional action. That additional action could include referrals to RAC or UPIC. It can be another round of review. It's really up to CMS to give us direction on what they want us to do going forward after that 3rd round of a review. This next slide is just a picture overview of what CMS has for the TPE process. So if you're chosen for the program, you'll receive a letter from Medicare, and that letter is letting you know that you were chosen for the program. This is the documentation we're going to want to see when we ask for that documentation within an additional documentation request or an ADR letter. And then we're going to start sending out those individual ADR letters. Keep in mind, you want to keep track of those letters. You want to respond timely. There's going to be a date, and you only have that time frame to get that documentation together and send it in to us. Otherwise, it's going to be a non-response. We look at, again, 20 to 40 claims. If you pass your review within that threshold, you're compliant. You will not be reviewed for, again, at least 1 year for that specific topic. I always like to piggyback with that. That does not mean in 1 year you will for sure be pulled for another review. It just means your PTAN gets put back in the big bucket of PTANs that we are able to look at. Again, with CGS, we offer education for all reviews, regardless if you went above or below that threshold to move on to the next round. And then within our education, if you are moving on to another round, you get that 45-day period. The next slide. So with spinal pain management, these are the codes that we have on review that pertain to pain management. So we're looking at the ESIs, that's 62323, spinal cord stimulation for chronic pain, those 2 codes there. And then we are looking at a couple of the facet joints also. These codes and the reviews and all reviews can always be found on that website that we went over yesterday. And if you weren't here, you go out to our website, CGS Medicare, you will click on the JB tab at the top. And from there on the left-hand side, if you scroll down, you're going to see medical review. Click on that, go to our MR activities page. But within that page, our medical review page, there's lots of great resources. But that MR activities page will show you all of our active reviews that we have going on, those that might be pending. We don't have any that are closed right now, but if they're closed, that you would see that also. And then great resources like the documentation checklist tool we touched base on yesterday, fact sheet, which is an overview of the LCD and or IOM. So those tools are what are available for all providers with all policies that are being on review. So the next slide will go over into what we've looked at so far in terms of spinal pain management. So from May of 2023, and when this slide deck was put together January 24th, we had completed 16 probes. So 16 rounds had been completed. Within those 16, we looked at 620 just spinal pain management claims. Now that's taking ESI, facet, all of those on that previous slide into account. I didn't break it apart policy by policy there. Within those 620 claims reviewed, we ended up with a 63.6% denial error rate of those 620. So we're still looking at a denial rate, and we will continue those on that did not pass that first round or second round into the 3rd round. But I can say after education, many of our spinal pain management providers, we're seeing great improvement. I probably should have did a slide just on the improvement rates, because we are seeing really good improvement after a round of TPE. And for our questions, let me jump into those before we start with Stacy. So you can move on to the next slide. It'll just kind of give a review of what Stacy's going to look at. Specific factors that trigger a TPE. CMS gives direction on what we can look at in actually the IOM. But what we're looking at is comparative reports of peer utilization rates, billing practices that might differ from those in that policy group. We get referrals from the CERT. We get referrals from UPIC and RAC and the OIG. CMS will give us referrals. So there's a lot of factors that go into consideration, and it's not just this one provider is billing a lot of spinal pain management, so we're going to put that provider in review. Nothing like that. There's a lot of components that go into place on why someone is picked for a review. I just saw that one had popped up last, so I thought I should answer that quickly before we move on to Stacy. You can take it over. Thank you all again for meeting with us today.
Stacy, before you start, we just want to tell everyone that pre-authorization or prior authorization is in respect to the hospital outpatient department procedures, not office or ASC procedures. But this criteria are extremely useful for us so we can meet appropriate criteria when we do provide these services in ASCs as well as office settings. Thank you, Stacy.
Thank you. And thank you, Dr. Berman and Jess. Yes, prior authorization is for the hospital outpatient department where they bill a 13X type of bill. However, it does impact you as providers because there are associated codes with the codes that do require prior auth. And if a particular code required prior auth and there was not a prior auth in place, any associated codes that a practice would bill would ultimately be denied as well. So on to the next slide, please. So prior authorization, as it was mentioned yesterday, is a condition of payment. It must be obtained before services are rendered. There are currently 8 service categories that require prior authorization. Cervical fusions and implanted spinal cord stimulators were added to the prior auth program on July 1st, 2021, and facet joint interventions were applied in July 1st, 2023 of last year. So with the prior auth program, excuse me, the slide's kind of covered up there. I cannot.
What is the slide? Okay.
Oh, there we go. Thank you.
Sorry.
So decisions for the prior authorization program are based on presenting medical documentation. A provisional affirmation is given, which states basically that the documentation most likely meets Medicare guidelines and regulations. If a non-affirmed decision is given, that's basically stating that the medical documentation presented will most likely not meet Medicare guidelines. It is for hospital HOPD settings, not for critical access hospitals or ambulatory surgery centers, or even procedures done within a physician's office. It is only for those settings that bill with a 13X type of bill. And as I mentioned, it does impact providers because if you provide a service that required prior auth, when you go to bill your associated codes related to that service, your claim could get denied because there was no prior auth on file. It is a working relationship between providers and that hospital outpatient department as far as being able to supply them with the medical documentation necessary in order to request a prior auth as well as to support any kind of claims. So for more information on the prior authorization program for certain services, you can actually access to cms.gov. If you actually type in prior authorization, you're taken to many links, including their webpage related to prior authorization. Next slide, please. So, with prior authorization, there are actually three types of submissions. We have an initial, a resubmission, and expedited. With initial prior authorization requests, it is only valid for one claim or date of service. We have 10 business days to complete a review. That does not include weekends or holidays. And so I oftentimes have to educate providers to be sure to allow us 10 business days to review your prior auth request. Resubmissions occur when that initial or resubmission request received a non-affirmed decision. This gives providers an opportunity to fix any issues and resubmit the request again. They can resubmit an unlimited number of times. Our medical reviewers actually reach out to providers to let them know what was missing with their documentation. We also have providers that email us at our education email box where we go into further detail as to why a particular request received a non-affirmed decision. So we make every effort possible to work with providers and educate them on what was missing so they can get that affirmed decision. What's great about the prior auth program is that you can resubmit an unlimited number of times. There's no cap on it. We have 10 business days to review a resubmission. So whenever you're resubmitting a prior auth request, you're going to have to add another 10 business days for that review. And as I mentioned yesterday, you don't have to wait 14 days before resubmitting. You don't have to wait 30 days before resubmitting. You can resubmit pretty much the next day with your request. Then there's expedited. Expedited could be an expedited initial or an expedited resubmission. This is where any delays could jeopardize the overall health or life of that beneficiary. The documentation must actually show that any delays could cause these conditions. If the documentation is not there, then we have 10 business days to review, not 2 business days. And we ask that providers do not select expedited based on a anticipated date of surgery. It won't work that way. We don't expedite prior auth requests because you want to do the surgery tomorrow. We actually have 2 business days to review an expedited request if it is determined to be a true expedited request. And we receive prior authorizations via mail, fax, ESMD, or even through my CGS portal. Next slide, please. So for facet joint interventions, the overall purpose is to relieve individuals with moderate to severe chronic neck or low back pain. Yesterday, I went over the types of documentation that we need for these particular requests, and one of which is that pain or disability scale that actually demonstrates that this patient has moderate to severe chronic neck or low back pain. So 3 types of procedures that require prior authorization include those medial branch block diagnostic procedures, the medial branch block intra-articular joint injections, and radiofrequency ablations. And of course, as we went over yesterday, there are certain criteria that has to be met with each and every one of these procedures. And a prior auth request has to be submitted for each procedure. We cannot take a date range, meaning you cannot submit one prior auth for 2 diagnostic. There has to be a prior auth request submitted for each diagnostic because it's only good for one claim or one date of service. So you have to submit a prior auth for each procedure. As was mentioned yesterday, there are a limited number of sessions. A session can be unilateral or bilateral. There are 4 MBB sessions per region in a 12 rolling month period. And with RFAs, there's only 2 sessions per region in a 12 rolling month period. We find that many providers actually struggle with the RFA route. They'll decide to do a unilateral approach versus bilateral. When a unilateral approach is taken, meaning they do the left one day and then they do the right on another day, you're taking up 2 sessions already for that patient for a 12 rolling month period. And of course, here below is the link to our LCD, and Dr. Lovelace actually showed you that LCD yesterday. Next slide, please. So here are the HCPCS codes requiring prior authorization for facet joints, which include your MBB procedures and your radiofrequency ablation procedures. Each procedure has to be reported based upon how many levels you're doing. So we have some single level codes, the 64490, the 93, the 33 and 35. These are all single levels. They can be requested by themselves. However, if you plan to do a second level, those have to be reported with the single levels, kind of like a stair step type of approach. You can't just request a 64491 without the 64490. If we just get a request that only contains a 64491, we will actually automatically reject those requests and send it back to the provider, letting them know you have missed a step in your request there. I have here kind of asterisks with the third levels, because 3 or more levels procedures may receive a non-affirmed decision, but can be considered on appeal under unique circumstances. This is one of those situations based upon our LCD. If we have a third level requested, we will partially affirm those requests, meaning we will affirm the 92 and the 90 if all the documentation is there, but we will not affirm the 91 based upon the current language in our LCD at this time. Until that changes, that third level, we will not affirm because of what the guidelines stipulated in our LCD. With the RFAs, these are a bit tricky because that 64634 and that 64636 codes actually go into more levels. Those are defined as additional levels. So it could be a second level, it could be a third level, it could be a fourth level. And if we see in the documentation that the intent is to do a third or fourth level, we will actually non-affirm those requests. And again, it's based upon the language in our LCD. Next slide, please. So this is the total prior auth requests that we've received for jurisdiction 15, which consists of Ohio and Kentucky. When it was launched on July 1st, 2023, this is the total amount of prior auth requests that we have received for facet joints in such a short period of time. It has become our #1 requested prior authorization service. As you can see, we've received over 11,000 requests. The affirmation rate at the time that this presentation was put together was at 57%. I believe it's over 60% now. We've had a total of over 5,000 affirmed requests. We've had a total of almost 4,000 non-affirmed requests. And as it was mentioned yesterday, the most common reason is related to missing pain scales. I can't stress that enough. We need to have a pain assessment pre and post to help substantiate the 80% needed to move on to the next procedure. And that's the part that most of these requests are missing. We have some partial affirmations. As I mentioned, we will partially affirm requests in which we will not affirm the third level, but we will affirm the first and second levels. And then, of course, we've had over 2,000 rejections. And as I said, rejections never make it to medical review. There's something wrong with the prior auth request form. We're missing information off of the form, etc. So rejections never make it to medical review. Next slide, please. So implanted spinal neurostimulators, again, these are warranted as a late or last resort for patients with chronic intractable pain. Other conservative treatments have proven to be unsuccessful, such as past surgeries, pharmacological, NSAIDs, steroids, muscle relaxers, etc., PTOT therapy, psychological therapies, anything that's been tried to help relieve this patient's pain. Other treatments determined to be unsuitable or contraindicated must have documentation indicating why. Patients have undergone a careful screening by a multidisciplinary team. And again, one of the major issues is that psychological evaluation conducted by an appropriate personnel for that. One of the other criteria that we look for is that the facilities include equipment and personnel available for follow-up care for these patients. We don't have an LCD on neurostimulators, but we do follow the NCD as stated here. Next slide, please. So the only HCPCS code that requires prior authorization for spinal stimulators is the 63650, and it's for the dorsal column only. Requests can be for a trial or permanent placement. If the permanent placement is in the same HOPD facility as the trial, we only need a prior auth for the trial. We don't need one for the permanent placement. But I do want to say that when you do receive an affirmed UTN, it is from the decision date on the letter. An affirmed UTN actually has 120 days from the date of the letter. So you can reschedule procedures within that 120-day time frame without having to submit another prior auth. If the permanent placement is in a different HOPD facility from the trial, we will need you to submit a prior auth request with updated documentation related to the trial. And what we look for is did the trial result in 50% reduction in pain and or analgesic use for that patient? Next slide, please. So spinal stimulators are our fourth highest requested service for prior authorization. For all of last year, we've received a total of over 1,400 prior auth requests for neurostimulators. Our affirmation rate is significantly higher with these than they are for facet joints at the moment. So our affirmation rate is at 81%. And we've received a total of 791 affirmed requests and 182 non-affirmed requests. And again, as it's been mentioned, as it was mentioned yesterday, that the most common reason is related to a missing psychological evaluation. We've only had 508 rejections here as well. And as I stated, rejections never make it to medical review. Next slide, please. So we do actually get audited for our prior authorization reviews. The MRAC, which is the Medical Record Accuracy Contractor, actually does quality reviews of our prior authorization. There are monthly reviews. They usually select a random number of requests that they want to review from the previous month. To date, we've only had 4 facet joint prior auth requests. Neurostimulators don't get picked as often as much as the other services do. I think we've only had maybe 1 or 2, and they've actually agreed with our decisions, including our facet joint request. We've had no disagreements from the MRAC thus far. We can, if we see anything outlying or if we're directed, we can refer providers to the RAC or the UPIC. But as it is, we only have the MRAC that actually audits our reviews for prior auth. And I believe that is it for me. Thank you. On the next slide. So any questions? Mm-hmm.
Before we jump into general questions, I was scanning the questions as the presentations were going, and there was a question about does CGS use computerized algorithms or artificial intelligence? And the answer is absolutely not. We are very heavy in data analytics as far as choosing providers and doing our TPE strategy and things of that nature, as well as for reporting. But CGS uses people. People are our power, and we have very good people, and they're trained very well. And our accuracy review results by several external entities show that. So to answer that question, we do not use AI or computerized algorithms in any sort when it comes to medical review. I'll turn it over to either Dr. Manchikati or whoever is going to manage the Q&A session and let y'all go forward from there.